So you just came on shift and you check the assignment board and bam, it hits you. Your stomach sinks, your palms start sweating. You literally would rather work triage for the next year than to take this patient assignment. And you do critical care all the time. But today is different. This patient is different. This is a ventriculostomy patient. And it's no wonder. These patients are often unstable, high acuity, and require constant assessment and precise management. That's why these are really considered halo procedures. High acuity, low opportunity. You may have seen one months ago, but you can't even remember the last time that you actually had to manage one. It's a very intimidating feeling. So in this video, I'm going to show you how to set up and manage a ventriculostomy so you can walk into that room with the confidence and the skills in order to take care of these types of patients. I am the Nurse G, and I'm bringing you another RRT. Alright everyone, I'm the Nurse G, and I'm back with you for another RRT. And we're going to show you how to set up an EVD in your ED. So external ventricular drains. I know we don't see them and they fall into that halo category. But I'm going to walk you through some real simple steps on how to set it up, how to manage it, and what to look for. So let's get into it. So you need your ventricular drain. You need your cranial access kit. You need a transducer. We'll go over why this is different than your A-line transducer. And you need a cable in order to deliver the transduced pressure to your monitor and give you a value. And that's all you need. It's not like it takes a brain surgeon to, hold on, wait a minute. Scratch that. Rewind. It takes a brain surgeon in order to place the EVD inside the brain, but it does not take a brain surgeon in order to set this up and monitor the patient. So that's where we come in. All right, now that you're ready to set up your EVD, go ahead and grab your ventricular drain here and open it up out of this box. It'll be wrapped in plastic, but just take that plastic off. Once you open it up, there's gonna be a few things. One is this. This is your leveler. Make sure you don't lose that, and I'm gonna show you where that goes on here. And it's kind of simple. All it has is this sterile part, so that's the part you don't want to touch. That's the part that gets handed to the surgeon. They've actually put it into the drain that they insert into the brain. And the rest of this is kind of simple. All you have to do is see here that there's a little button. Just press that button there. And it actually opens up these little grippers. And you put this on your IV pole using those grippers. So press it, hold it, put it on there, and let it go. All right, after you've unraveled your level, there's two sides. One has a ring and one has a little push tab device. This push tab goes right in this little hole right here. Go ahead and put it in there and just push it and you'll hear it snap in. Now, that's your leveler. You're good to go. All right, this is the business end right here. This is what we're gonna be working with. So the next thing you're gonna need is that transducer that you open up. And just like with the A-line, there's pieces in here you don't wanna lose. So when you first open up your transducer that looks like this, it does not have a pigtail on it. And that is different than your A-line. But also, just like the A-line, you have a vented cap. So in your kit comes a non-vented cap. So make sure you replace the vented cap with the non-vented cap. All right, so this piece right here is where we're gonna hook up our transducer and how we're gonna flush the system. And I'm going to tell you that we do not ever infuse or flush a system when we have it hooked up to the patient. This is all to be done before it's hooked up to the patient. Go ahead and take your transducer and pull off your tab and pull off the cap on this end. And these will actually go together, but it might be a little tight, but you got to screw this on there. Now that you have everything hooked up, you're ready to flush the system. You need to remember that you never flush a system that's hooked up to a patient, ever, ever, ever. All right, take your normal saline and undo your cap here. And what I like to do is just screw it right in so the system's kind of all connected here. And take your stopcock and turn it off to essentially what will be going into the patient but is not connected to the patient yet, because we want to prime this system up into the drainage device. So let's prime that system. You've already primed the top part of your system. Now we're going to turn the stopcock off to your graduated cylinder or your collection device, and you're going to flush the line that it eventually will be connected to the patient. Now, before you can get an ICP reading, we need to level the system. Grab your string and leveler and stretch it across, looking for the landmarks of the external auditory meatus. Once you get it here, get the bubble.
Double bubble. Double bubble.
On the level in between the black lines. And you can do this by either adjusting the bed up or down or the system on the pole in order to get the system level. Now that you got the system leveled, you're ready to start zeroing. But first, grab your transducer cable, plug it into the transducer, and then plug the other end into your bedside monitor. Once this is complete, we are now ready to zero the system. So I want to take a minute and talk about the numbers on the side of the ventric here. These numbers come in two flavors, if you will. One is millimeters of mercury and one is centimeters of water, and it shows the relationship between them based on the offset numbers here. So these numbers and this bar here is actually set by the neurosurgeon or the surgeon at bedside. They sometimes will tell you leave it here once they leave bedside, or you might come back from CT and based on what they see or based on the opening pressures, they might adjust this up and down, and then they'll follow up with an order, or they may leave the drain off, go to CT, and when you come back, they might give you an order that'll prescribe where it needs to be in either centimeters of water or millimeters of mercury. So pay attention to which one they actually set the drain at, and that's the only time we really move this drain pressure. So let's say they want it at 15 millimeters of mercury or 20 centimeters of water. You basically squeeze the tabs on the side here and adjust it, but that's not how we level the system. We went over leveling, and that's by moving the entire system up and down, not by adjusting the drain pressure level. What this means is that any pressure over 15, any intracranial pressure over 15 will actually start to drain CSF into your drain. And that's actually what you're prescribed and setting when you move this. So this should not traditionally be moved up and down all the time. This is usually a fixed number prescribed by the doctor in an order that says leave it here, and then over time they might adjust that based on the condition of the patient, but this is not moved frequently. It's basically set, and then when you need to make adjustments to zero or you need to make adjustments to get an ICP reading, that's done by moving the entire system up and down, not the drain pressure level. So because you want to zero it to atmospheric pressure, currently it's off kind of to everything here. So what you want to do is you want to open this up so it's actually exerting pressure.
God, the pressure!
Into the system. Go to your monitor and hit 0 ICP. Should give you 2 beeps. And now you know it's zeroed. Atmospheric pressure is being exerted onto our transducer, and we're going to negate whatever pressure that is. So we just get the intracranial pressure. All right, now that you've zeroed your A-line, you actually just need to get a reading of your ICP. In order to do that, you need to turn your stopcock here. Currently, the system is on to drain and off to your transducer. So the pressure that comes up your pressure tubing can't be exerted onto your transducer because it's off. So you got to turn that off to the drain so that it makes a complete system and now is exerting pressure onto your transducer. Once you have that, you should see a waveform and a measurement. Once you record that, let it go a couple oscillations across, and once you record your ICP measurement, The key is that you have to return this knob, this stopcock, down off to the transducer, which will cut the reading to your monitor, and it'll start beeping at you because it'll say you can't read it anymore. But what it does is it puts it onto the drain, which is exactly what you need. As you have buildup of intracranial pressure, the CSF will be displaced, which is the point of this extra ventricular drain. So you want to make sure that the system is onto the drain. The other reason that we flush this with saline is that this tubing is super long. And if you didn't fill this with saline, it would take a really long time for all the CSF that gets displaced to reach this, and you wouldn't know how much the patient's putting out. So the amount displaced will be in here, will first be saline, and let's say it's 2 mLs. That 2 mLs will actually be like right here on the tube that's connected to the ventricular device. So you wouldn't be able to really measure that, but you can measure it here in the amount displaced, or the saline that's displaced into the graduated cylinder. So every hour you should be recording how much this is putting out, what your ICP is, and you should be getting those measurements along with a neuro assessment every hour. Hey everyone, thanks for watching. Hope you enjoyed the video. Check back here for more videos on everything emergency medicine. Leave a comment in the comment section on what skills or topics you'd like to see from us. And remember, keep your skills sharp, your vital signs stable, and I'll see you at the next RRT.